I'm Umair Khalid. I'm one of the social media editors at JACC Cardiovascular Interventions, and it is my great pleasure to welcome Dr. Chiardetti for this interview. Thank you so much for joining us today, Dr. Chiardetti.
Thank you. It is a pleasure to be here, and thank you for the invitation and the presentation.
Of course. So today we will feature your publication titled Drug-Coated Balloons in the European Registry of Chronic Total Occlusions, or ERCTO. So I'll go straight to the first question, Dr. Chiardetti. I'm very interested in the data set, the registry that you're studying these questions. I saw that we have more than 40,000 cases. So that's obviously a strength, but overall, what are other strengths and limitations of this huge registry? If you could tell us about this real world registry.
Sure. The EuroCTO registry is unique both for its sheer scale and granularity. Over 40,000 CTO-PCI procedures across 184 centers, and it captures not only volumes, but also detailed procedural strategies and outcomes. And this gives us a very realistic picture of contemporary CTO-PCI practice across Europe. That said, the limitations are equally important. Outcomes are operator reported, and lesion characteristics are visually assessed without a core lab, and most critically, there is no follow-up beyond hospital discharge. This means we can describe procedural strategies and acute safety, but we cannot infer anything about restenosis, reocclusion, or long-term clinical outcomes.
Perfect. Thank you so much for your answer. And next, I would want to know the results. If you could briefly, for the audience, go over the results briefly. And then also, like I know this paper is about use of DCBs, and I'm curious if we can identify certain CTO subsets where the interventional cardiologist should strongly consider a DCB strategy over a stent strategy.
That's a very important point. The first result to highlight in the study is the steady rise in DCB use over time, increased almost fivefold in 7 years. DCB treated cases showed shorter stent length, lower contrast use, and comparable in hospital complications with lower rate of pericardial tamponade. But it's important to stress that these results don't prove superiority of drug-coated balloons over drug-eluting stents. They only reflect where operators chose to use drug-coated balloons, so in distal disease, small caliber vessels, in stent restenosis, and through bifurcations. Those settings are logical candidates, but the registry cannot tell us they are the right ones. It only tells us where practice is evolving.
Thank you so much. And I agree, like I know there are certain limitations like you mentioned, but I still think very promising results for use of DCB, including the benefits you mentioned. One thing that really is interesting is like the lower rate of pericardial tamponade in the DCB subgroup. Do you think there is any hint of causality, or do you think it's related to patient selection?
I'm glad you raised this question. The signal of a lower tamponade rate in DCB cases is intriguing, and mechanistically there is also a plausible explanation. Actually, avoiding long stent implantation and aggressive post-dilation in fragile distal diffusely diseased small vessel likely reduce the risk of perforation and tamponade. But given the very low absolute numbers and borderline significance after adjustment, we have to be very cautious to claim causality. These patterns may well reflect case selection rather than a true protective effect.
Perfect. That makes a lot of sense. Thank you so much for clarifying that. And lastly, Dr. Chiardetti, what are the future areas of research in this particular field, like the use of DCBs and the CTO-PCIs?
Yeah, I think we need randomized trials to understand the ideal CTO subsets for DCB use. We also need studies, and I think in particular intravascular imaging studies to understand when the result can be considered optimal when you use a DCB and when dissection can be left unstented. And we also need to clarify whether a DCB-only strategy is feasible in CTO-PCI, given that in the EuroCTO registry, the majority of patients receive the hybrid approach. And finally, long-term follow-up will be essential to know if reducing stent burden translates into lower events. So I think that future studies should also compare different drug formulations, since our registry shows paclitaxel is predominant, but limus-based balloons may offer different safety and also efficacy profiles.
Perfect. Those are all great points. And thank you again for joining us today, Dr. Chiardetti, and congratulations on your work. This is a great study.
Thank you. It was a pleasure to be here.